Welcome back to the deep dive. Today we're digging into something pretty incredible inside us, a system that manages, well, a huge amount of complexity, uh, chemistry, logistics, and it does it all without really checking in with headquarters up top.
Yeah, we're talking about the enteric nervous system, the ENS. You hear it called the second brain a lot these days, and for good reason.
Exactly. So our mission today, for you listening, is to really get a handle on this autonomous system that runs your gut. How does it manage to be so independent? How does it still talk to the central nervous system?
And crucially, what happens when things go wrong? When this normally smooth operation starts causing real problems?
Right. Because the research is clear, isn't it? This isn't just some simple wiring.
Not at all. I mean,
Right.
it's actually defined as its own division of the autonomic nervous system. It really can operate autonomously, managing all the digestion, the muscle movements, blood flow,
Yeah.
minute by minute, without direct orders from the brain.
Wow. Okay. But it does still communicate, right? It's not totally cut off.
Oh, absolutely. That connection, that pathway through the autonomic nervous system is always there for, let's say, status updates or broader commands. But the local control, that's the ENS's domain.
Okay, let's unpack that autonomy then.
Yeah.
We're calling it a second brain. The structure must be, well, sophisticated. Where does that independence actually come from, physically?
It's literally built into the walls of your gut. The sources describe it as containing everything it needs: nerve fibers, support cells, and just vast numbers of its own neurons, gangly cell bodies.
Its own neurons.
Yeah, millions of them. And they're organized into these complex local circuits, reflex circuits, so the system can sense something, process it, and trigger a response, maybe release an enzyme, start a muscle contraction, all right there within the gut wall.
So it makes decisions locally, super fast.
Exactly. Independent of the brain or spinal cord for those immediate actions, it allows for incredibly rapid responses to what's happening right there, right then.
That sounds like a huge evolutionary advantage.
Mhm.
I mean, if your main brain is busy, say, running from a threat or dealing with something stressful,
Right.
your digestion doesn't just shut down. That local processor keeps things moving. It's vital.
Absolutely vital. And because it's so vital, it's highly organized. It's not just a random mess of nerves. It's structured into two main layers, these plexuses, and they each have different jobs.
Okay, two layers. What are they?
So first you've got the myenteric plexus. You might also hear it called the Auerbach plexus. Its location is really key. It sits right between the muscle layers, the outer longitudinal and the inner circular ones.
Okay, between the muscles, so it controls movement.
Precisely. Think of it as the gut's movement coordinator. It regulates motility, the muscle contractions, how strong, how frequent along the entire GI tract. It's responsible for those big waves, peristalsis, that push food along.
Got it. The big picture movement guy. What's the second layer?
That's the submucosal plexus, or Meissner plexus. This one's located a bit deeper, closer to the inside, between the lining, the mucosa, and that circular muscle layer.
And its role. More fine-tuned.
Exactly. It's more like the quality control and local manager. It handles things segment by segment, controlling gland secretions like enzymes or mucus, managing absorption of nutrients, and even regulating local blood flow right in that specific patch of intestine.
Okay, that makes sense. One handles the pushing, the other handles the local chemistry and absorption. But for them to work so well, they need information, right? How does the gut actually know what's in there or how full it is?
It has its own built-in sensory system, like internal spies, really. The sources point to two main types of receptors doing this job. First, you have mechanoreceptors.
Mechanical, so they sense physical things.
Yeah, physical stretch or distension. They basically measure how much the gut wall is being stretched at any point. They're signaling, okay, we're filling up here, or time to move this along.
Makes sense. And what about the contents, the actual food and chemicals?
That's where the chemoreceptors come in. These guys are monitoring the chemical environment. They check things like the pH level, are there fats, are there proteins, what nutrients are present.
Why does it need to know that?
While the ENS uses that chemical data to decide what to do next. Does it need to release more acid, secrete specific enzymes, maybe slow things down a bit to absorb those nutrients properly? It's all based on that local chemical feedback.
Wow. So it gathers data locally with these sensors, processes it through the two plexuses,
Yeah.
myenteric managing the muscle push, submucosal handling secretions and absorption based on the chemistry.
Hmm.
It's incredibly efficient, runs on autopilot.
Pretty much. Which naturally leads us to the next critical point. What happens when that autopilot system starts to fail? When this independence breaks down?
Right. We move from efficiency to, well, problems.
Hmm.
How do we define ENS dysfunction?
Simply put, it's when that normal control of GI motility, secretion, and coordination goes haywire. It happens because there's a disruption in that intrinsic neural network, the system we just described within the gut wall. The local reflexes aren't working right, or the communication along the gut-brain axis gets noisy or damaged.
And this isn't some rare, obscure thing, is it? When people talk about chronic gut problems, this dysfunction seems to be at the heart of many common issues.
Absolutely. We're talking about really widespread conditions, things like irritable bowel syndrome, IBS, which affects so many people, with the constipation, diarrhea, or both.
Yeah.
Then there's gastroparesis, where the stomach emptying is significantly slowed down, almost paralyzed in some cases. And also more structural examples like Hirschsprung's disease. Even though it's rare, it's a very clear example of the ENS architecture itself failing.
Okay, so what causes this breakdown? The sources mention a really diverse range of factors, right? It's not always something that starts in the gut itself.
That's one of the most interesting parts. The causes, the etiology are really varied. You have congenital problems like Hirschsprung's. That's not just bad function, it's a developmental failure. The enteric neurons just didn't migrate to a section of the bowel during fetal development. So that part of the gut literally lacks the nerve network.
Wow, okay. What else?
Then you've got major neurological disorders, things like Parkinson's disease or autonomic neuropathy, often seen in diabetes. These conditions can directly damage or negatively affect the neurons in the gut, leading to significant GI symptoms. It shows how connected the central nervous system and this second brain really are.
And what about things we might introduce ourselves or external factors?
Definitely. The system's vulnerable. Things like severe infection or chronic inflammation, think Crohn's disease or ulcerative colitis, can physically damage or even destroy enteric neurons over time. And then there are medications. This is a big one. Opioids are a classic example. They're well known for slowing gut motility dramatically. But also certain anticholinergic drugs can interfere significantly, sort of overriding the ENS's normal pacing.
Now we have to talk about stress, right? You mentioned earlier it disrupts the gut-brain communication. Does the research really show stress can physically mess with how the ENS works, not just how we feel?
It absolutely does. Chronic stress isn't just a feeling. It creates a physiological state of alarm. Stress hormones constantly flood the system, and they directly impact the neurotransmitters and signaling within the ENS. This affects motility, it affects secretion, and crucially, it affects sensation in the gut.
That leads perfectly into the symptoms then. If the ENS is disrupted, what's actually happening physiologically?
So the dysfunction basically boils down to three main problems happening in the gut. You get abnormal motility, things moving too fast, too slow, or uncoordinated. You get altered secretion, not enough, or too much fluid, enzymes, etc. And you get this thing called visceral hypersensitivity.
Okay, hold on. Visceral hypersensitivity. That sounds important, but a bit technical.
Yeah.
Can you break that down? What does that actually feel like for someone?
Yeah, it's critical, especially if understanding chronic gut pain. Essentially, visceral hypersensitivity means the volume knob for sensation in your gut is turned way up.
Okay.
It's a little gas moving, a small muscle twitch, you don't even notice them. But with hypersensitivity, those normal minor events are perceived as painful, sometimes intensely so. Like a normal gut activity suddenly feels like a major cramp. The system is overreacting.
Okay. That explains a lot about conditions like IBS pain. So you combine that hypersensitivity with the motility problems and the secretion issues.
Yeah.
What are the common symptoms people experience?
Well, you see those really frustrating changes in bowel habits. We mentioned chronic constipation or chronic diarrhea, or sometimes cycling between the two. Abdominal pain and bloating are also really common signs that the ENS isn't coordinating things properly. And then in conditions where motility is really slowed down, like gastroparesis, the symptoms are directly related to that lack of movement. People feel persistent nausea, they might vomit, and a classic sign is early satiety.
Feeling full really quickly.
Exactly. Feeling totally full after just a few bites of food because the stomach just isn't emptying like it should.
Yeah.
And of course, the sources remind us of the severe end, like infants with Hirschsprung's, showing really clear signs like not passing meconium, a very swollen abdomen, and vomiting.
It sounds incredibly tricky to diagnose, though, because these symptoms, pain, bloating, changes in bowel habits, they overlap with so many other things.
Yeah.
How do doctors figure out it's specifically the second brain, the ENS? That's the problem.
Yeah, diagnosis is definitely a process. It starts with a thorough history and physical exam, of course. But
Yeah.
then you often need specialized testing to really see how the gut is functioning or not functioning.
What kind of tests are we talking about?
We use motility testing. Things like gastric emptying scans, they use a radioactive tracer in food to see exactly how long it takes the stomach to empty. Or colonic transit studies, which track markers as they move through the large intestine.
Measuring the speed, basically.
Measuring the speed and pattern, yeah. And crucially, there's manometry. This is where we get more detailed. It involves placing thin tubes with pressure sensors inside the esophagus, stomach, small intestine, or colon.
To measure the muscle contractions directly.
Exactly. It measures the force, the coordination, the timing of the muscle squeezes. It's like putting a pressure gauge and a rhythm detector right inside the gut to see if those peristaltic waves are happening correctly. It tells us how it's moving, not just if it's moving.
And if they suspect a structural problem, like missing neurons in Hirschsprungs.
Then the gold standard, though it's invasive, is a biopsy. Taking small tissue samples from the gut wall allows pathologists to look under the microscope and actually see the neurons. They can confirm if the enteric neurons are absent, damaged, or reduced in number. That gives a definitive answer about the physical state of the ENS in that area.
Okay, so once a diagnosis points towards ENS dysfunction, how is it treated? It sounds complex, given all the potential causes and symptoms.
It really requires a comprehensive approach, often multifaceted. The foundation, according to the sources, almost always starts with diet and lifestyle changes. This isn't minor tweaking, it can be crucial.
Like what, specifically?
Things like eating smaller, more frequent meals instead of large ones. Adjusting fiber intake sometimes more, sometimes less, depending on the issue. Staying well hydrated, and very importantly, identifying and avoiding specific trigger foods that reliably make symptoms worse for that individual.
That makes sense. Start with the inputs. What about medications?
Yeah, medications play a big role in managing symptoms and sometimes addressing the underlying mechanism. If slow motility is the main issue, doctors might use prokinetics. These are drugs like metoclopramide, or sometimes erythromycin, used off-label for this, that chemically stimulate the gut muscles to move things along faster.
Okay. And for other symptoms?
For pain and cramping, antispasmodics can help relax the gut muscles. For constipation, obviously, laxatives or stool softeners are common. The choice really depends on the specific pattern of dysfunction.
You mentioned something earlier that sounded really key, linking back to the gut-brain connection, neuromodulators.
Yes, neuromodulators. This is a fascinating area. Often these are medications technically classed as antidepressants, like tricyclics or SSRIs, but they're used here in very low doses.
Not primarily for depression, though.
Usually not. The goal here is different. They act on the nerve pathways between the gut and the brain, that communication superhighway, the vagus nerve being a major player. They seem to modulate how pain signals are transmitted and perceived. They can essentially help turn down the volume on that visceral hypersensitivity we talked about.
So you're treating the gut pain by adjusting the signaling traffic between the two brains. That really highlights the connection.
It absolutely does. And it also explains why non-drug approaches are often used alongside medical treatments. Things like behavioral therapies.
Such as?
Biofeedback can help people learn to control certain bodily functions. Relaxation techniques are important. And cognitive behavioral therapy, CBT, is increasingly used.
CBT for gut problems. How does that work?
Because CBT helps people manage the psychological factors like stress and anxiety, which we know directly impact ENS function and pain perception. It helps break that vicious cycle where gut symptoms cause distress, and distress worsens gut symptoms.
Right. And I suppose in some cases, surgery is needed.
Yes, particularly for structural problems or severe intractable dysfunction. For example, in Hirschsprung's disease, the definitive treatment is often surgically removing the segment of the colon that lacks the enteric neurons. Or sometimes surgery is needed for severe blockages or motility issues that don't respond to anything else.
Okay, this has been a really thorough exploration. We have established the ENS isn't just plumbing. It's this incredibly sophisticated, largely autonomous system, a tree-second brain. It manages local digestion through those two key layers, the myenteric and submucosal plexuses.
Yeah, and I think the crucial takeaway from the research is understanding both its independence and its vulnerability. It's designed to run locally, but it's deeply interconnected with our overall health, affected by everything from birth defects and neurological diseases to infections, medications, and very significantly, our mental state.
The treatment approach really reflects that, doesn't it? Using motility drugs alongside neuromodulators that tweak brain-gut signals, and even psychological therapies.
Exactly. It's the perfect example of that mind-body connection in action. You can't really treat one effectively without considering the other when it comes to the gut.
Which brings us to a final thought for you, the listener, to ponder. If the enteric nervous system has this remarkable degree of physical independence, enough to manage digestion all on its own, what does its clear susceptibility to psychological stress and its responsiveness to treatments like cognitive behavioral therapy tell us about the real limits of that physical autonomy? How much is its independent operation constantly being shaped, maybe even overridden, by our thoughts and feelings? Something to consider the next time you feel that flutter or that knot in your stomach.